Welcome to the Scottsdale Top Docs podcast, where we share a mission to improve access to care and prevention, as well as planning for the future. Our goal is to help people live healthier, happier, more informed lives. We believe that healthcare isn't a job, but a calling to serve, and the best care begins with conversation. Now on to today's episode. Hello, and welcome to today's episode of the Scottsdale Top Docs podcast. I have the distinct pleasure today of introducing Dr. Todd Hurst of HealthspanMD. Now, Dr. Todd Hurst has a very extensive cardiology career here in the Valley, and we'll get into a little bit of that. But I wanted to bring him to the office today, actually, because we just had our Scottsdale Top Docs third quarterly meeting, and I needed him here to speak about the transition of medicine. And today in medicine, it's a little bit different. You have a lot of options. You have this insurance model that everybody who ever went to medical school understands, that we have a sense of altruism, that we are designed to serve the community, the needs of a patient, do no harm. And then we understand that we have to operate inside of a construct that is based on the insurance reimbursement model. So Dr. Todd Hurst, tell me a little bit about your transition from regular medicine, meaning insurance-based model, you spent 20 years at Mayo Clinic, into building your own business.
Yeah, so it's been a great journey. I learned a lot along the way. There's been some pain and suffering, but it was necessary pain and suffering as well. I guess my perception of what high quality care is really has been the thing that's changed the most. And early in my career, I wanted to save lives, and I thought that expert medical care was really the foundation of that. What I learned over time, both through my clinical experience and reading the research, is that high quality healthcare involves more than just expert medical care. Certainly, we want places that can take good care of us when we're sick, but we need to move beyond that, more of a proactive approach, looking for those opportunities outside of the doctor's office to achieve the best health. Mm-hmm. And, that's habits, nutrition, physical activity, sleep, stress, avoiding toxins, depending on the individual. But, what I've also realized is that those aspects of health that are so important often aren't covered by insurance. Now, that is changing a bit, but I would say, that model of saying, well, I'm going to accept the health care that my insurance will pay for, often will leave people in a situation where they're not getting the high quality care that they need and deserve.
So what did a typical appointment look like for you when you were just in that model, when you were in the healthcare industry in a hospital? What was a typical appointment with a patient like for you?
Yeah. So most of my career was at Mayo Clinic, and I was blessed to have time with my patients there. I would get 45-minute appointments. I will say in my practice now, my patients get about an hour and a half with me and my nurse practitioner. So we really take our time to listen. And really, I need that time to be able to understand the complexities of this, because everybody's unique. Everybody comes with their own goals, their own objectives of what they want to accomplish. And if I don't understand what those are, how am I going to advise them on how they can achieve those goals? And so I think that having that time. Now, when I left Mayo Clinic, I went to another healthcare organization. Mm-hmm. I won't mention names, but there, the typical cardiologist saw 25 or 30 patients in a half day.
Oh,
so
is that even 5 minutes?
Exactly. Less than 5 minutes. A lot of times the doctor would just walk in. The nurse practitioner would see them, create the note and everything. The doctor would go in and just, would be in there for 2 or 3 minutes and then say, this is what we're doing, and move on. And, unfortunately, I don't say that as an indictment of the doctors. Frankly, the doctors don't want to practice that way. But
of course,
in an insurance-based model, when you're getting $90 for a return visit, how are you going to spend an hour with patients? You're not. You're just not going to make that work financially. So, insurance-based only models, generally the doctors have to see 25 to 40 patients a day to make that work. Mm-hmm. Doctors don't want to do that. Patients certainly don't want that either, but that's the only way that it's financially sustainable.
Okay, so you're a cardiologist, you're a specialist. Everybody thinks cardiologists make like basically $1 billion a year. And as
a little less,
a little bit less than
yeah.
$1 billion. Okay, perfect. So in a roundabout way, I kind of wanted to ask you, transitioning into your own business, it had to actually have created some amount of sacrifice. So what was the inspiration for that sacrifice?
Yeah, that's a really great question. I've thought about this a lot, and it certainly wasn't foresight and intelligence. I'll tell you that much. I've often said, like, why would I have done that? And frankly, the reason, and I can't explain this, is I didn't have a choice. Like, I knew that this is what my purpose was in my professional life. Like, I knew this was something I was going to figure out. And frankly, I failed a lot. Like, I started this in 2009. Here I am 15 years later. I have a practice. It's thriving, but I've sacrificed financially, frankly, millions of dollars in money opportunities and also investments in my practice. Logically, that was not the right decision, but I didn't have a choice. Like, that was what I was going to do. And frankly, at one point, I had to take a step back after hitting that wall multiple times, and when you're that day of reckoning, and you're thinking, what am I doing here? Like, I could just go out, be an employee, make that $500,000 to $600,000 a year, and just be comfortable. And I realized that even if it's going to fail in the long run, I have to do this. Like, I can't live with myself and my integrity of who I am, who I value myself as, if I don't continue to push this.
So that hits me right in the heart. When I'm a physical therapist, I never got into that because I was like, oh, I'm going to be rich. But I grew up in a really small town and my family did foster care. And these kids came with all these different needs. And I had no idea that the stuff that we did, like tummy time, was so important. The development of the nervous system, the muscular system, like how we are able to turn something into movement, fascinated me. But not most people are really dedicated to going to that much school. So specialists are few and far between, but most people have a need to help other people. But when you find that moment where you're like, my calling is to do more than what a system is allowing me to do, it doesn't matter if you are an entrepreneur in big finance or you're a cardiologist at a renowned hospital, you have to do something. And I think that's where a lot of providers are in healthcare right now. I'm going to hand this interview over to my good friend, Dr. Shana Johnson, in a moment, who has been a longtime fan of your career and actually just met you recently. But she has followed your writing because she also has done quite a bit of journalism in the healthcare space. She's wonderful. And she's a little bit more of the nerd out kind than I am. So I really just wanted to say thank you so much for sharing your passion, the fire that you have for changing healthcare in a positive way is why this group was made. But people need to hear these reasons of why healthcare is shifting to private a lot and how they can access care that's better, even within the system, and who they go to. And they need to be able to identify a provider who cares that much. So thank you for your ability to do that as a specialist. And I'm going to hand it off to Dr. Shana.
Efforts like physical therapy pay great dividends when it comes to improving the range of motion, when it comes to improving the quality of a person's life.
You know how to change the way of life of people, which is a wonderful thing to do, to know you're doing that. Because I'm sure that without your help, I can do more than I thought I ever could. It's very important to have a way of moving around. You know, maybe you're not doing much of it moving, but you're moving. And I give you an A+. So I appreciate you very much. And that's the truth.
Hi, I'm Shana Johnson, Operations Board Member here at Scottsdale Top Docs, and I have the delight today to talk to esteemed cardiologist, Dr. Robert Todd Hurst, about his new innovative practice called HealthspanMD. How is HealthspanMD different from, say, a traditionally delivered heart care?
Yeah, so traditional healthcare, I think, is more of a reactive approach to health. So, that's the way that I was trained. I'm a traditionally trained cardiologist. I did my residency and fellowship at Mayo Clinic. I was on staff there for 13 years, and that's an important aspect of health. That we need doctors and institutions like Mayo Clinic, many others, to take care of us when we're sick. That's been a critically important aspect. But I'd say that actually healthcare and with that, they become so good at treating acute illness that now the problem is more chronic illness. And chronic illness, the things like diabetes and high blood pressure and high cholesterol, these are now the problems that are really a burden on people in the United States. 60% of adults have at least one chronic disease. And that is not best treated with an episodic approach with a prescription. That's more, needs a comprehensive approach that includes other things outside of the doctor's office, like lifestyle, nutrition, physical activity, sleep, and stress, if our patients are going to get the best approach. So I think of HealthspanMD as the care, one, that I've always dreamed of providing for my patients. One, expert medical care, yes, but also addressing the opportunities for people to avoid health problems in the future, and then get that comprehensive approach. We have an entire team of people, registered dietitian, exercise physiologists, personal trainers, health coaches, stress management specialists, mental health specialists, to be able to give people all of the aspects of health that are so important in people achieving their best health outcomes and living that long and vital life.
And earlier today, you talked about how when it comes to changing lifestyle patterns that improve health, people will often say, well, I know what to do. And one thing that you discovered is it's all in the execution. How do you help patients execute improving their lifestyle habits to reduce their risk of preventable disease?
Yeah, it's a great question, one that I struggled with. I will tell you, early in my career, I would have told you, I don't think people change, maybe 10%. And the reason why I said that, and the reason why most doctors feel that same way, is because of the way we have approached behavior change. We tell people, hey, eat less, move more, quit smoking, and then I'll see you in 3 months. That's not how people change. I also have learned, though, that you have to meet people where they are. If they're not ready to change, I can't solve a problem that they don't see. But where I think my advantage is in lifestyle change and getting people on board with achieving their goals. Really, I think it's most important as I emphasize to them, I'm not here to help you achieve my goals. I'm here to help you achieve your goals. Is that one, I often get people at a time when they're amenable to change. When they've had a health scare, whether that was a heart attack, whether that was a new diagnosis of high blood pressure, high cholesterol, or they have had a family member or friend that has had a disastrous health outcome. And then they say, you know what, I need to pay attention. I need to look for, the opportunities to stay healthy. I also really emphasize the first question on my questionnaire is, what is your why? Like, what is that emotional reason why you're not willing to leave extra healthy years on the table? Oftentimes, that's not about us. People don't often say, well, it's all about me. They talk about their kids, their grandkids, their purpose, their mission. There's things outside of them that they say, I need time to do this, and I need good health to do that. And then I think the other aspects of behavior change that I have been able to incorporate in my practice that have been really helpful is giving people that clear path. Just telling people, oh, get healthy. Well, what does that mean? Around nutrition is a really good example. Our nutrition program is agnostic in source. Like, we're not all vegan or vegetarian or Mediterranean. I know all of those diets can be really effective, but it's identifying the right people for the right diet And even if I knew what the right diet was, if you're not going to eat it, that's not going to be very helpful. So giving people the clear path and then breaking it down into actionable daily steps, things that you're doing and you measure the results and you adjust accordingly. So that was one of the things that I learned early on when I was trying to figure out how to help my patients with achieving their health goals is that we had an ability to track results. And it was so prominent that I ended up telling people, if you want results, track. Because if you track, you're going to get results. And if you don't track, you're not going to get results. And so even that simple step can be really helpful. But then build on those wins as well. Like, the problem with healthy lifestyle changes is often it's going to take a while. You don't get the beach body in a year. You don't reverse the diabetes in 3 months oftentimes. Being able to show people the wins along the way can be really powerful. So, that combination. And then, I tell my patients, since I have health coaches for all my patients, every patient in my practice has access to a health coach. And I say the health coach isn't there to tell you what to do. They're there to be your partner. If you want to go faster, if you want to increase the likelihood you're going to have success, use a team, use the support, the accountability, the encouragement of that team to help you get there.
You mentioned that it's really important to track. If you want to see results, you need to track what you're doing. What measures do you track to help patients reach that goal?
Yeah, so there's certain aspects of health that are research tells us are really important. Blood pressure, cholesterol, blood sugar, insulin. I look at results as well to help guide interventions from a lifestyle standpoint. So body composition, just looking at weight is a really blunt tool to assess health. But when you know muscle mass, visceral fat, body fat percentage, then you get some really great clues on what is going to be the intervention that's going to be most aligned with that person's physiology. And then fitness is also a really great measurement as well in predicting longevity. But I will say this, what is important in tracking is unique to each individual. They decide which one it is. So my coaches will talk to them, say, okay, what's your why? What are your objectives? And they'll say, for example, somebody will say, well, I want to lower my blood pressure. Oh, well, Dr. Hurst says that, nutrition and physical activity, sleep is very important. What do you think is most important? And they say, my nutrition. That's really want to start. Because even if I know nutrition is their biggest issue, if they don't know that, starting there is not going to be the fruitful path.
Yeah, self-awareness is so important.
Yeah. And challenging. I have my own health coach. And I tell my patients that I have this health coach. Do I need her to educate me on healthy lifestyle? I do not. She's delivering my system. But what I need is accountability. And I also need my blind spots pointed out because I have them like everybody else. And I'll give a good example. This was a visit that I had with my health coach about 3 months ago. And she says, okay, well, what do you want to do? And I said, my body fat percentage has gone up a little higher than I want it to be. I want to lower my body fat percentage. She goes, okay, well, when was the last time that you were where you want to be? And I said, oh, this is 2 years ago. And she says, oh, what were you doing then? And I said, I was running, 4 miles 4 times a week and I was lifting weights. And she goes, okay, well, what happened? And I said, oh, I had injuries. I can't run anymore and all this. She goes, okay, well, what are you doing now? And I'm like, about 30 minutes of walking 2 or 3 times a week. And, and it was just like so obvious. Yes, here's the problem. This is what I need to work on. But I needed somebody else to point it out to me.
Yes. And what I'm hearing from you is that algorithm-based medicine doesn't work for many people.
Amen. I tell people all the time, if you meet an expert and they say there's only one way to do it, that person is either not telling you the truth or they're not experienced enough to know the complexity and variation of individual people. I think this is an important thing in the longevity space. There's often PhDs that are brilliant. They know a lot of the research. They bring an important aspect to that. But the people I gravitate to are the clinicians, because the clinicians have been humbled. They've been humbled by the variation and the complexities of each individual and how important there is no one size fits all for everybody.
I couldn't agree more. I practice more in the chronic pain space, but it's a similar issue where there might be 5 things you typically do to address the chronic pain, but each patient's answer is a different one of those 5.
Yep.
For some, it's stress. For some, their meds aren't right. Yeah. So anyway, your point is very well taken.
Yeah, well, one of the people early in my career that really taught me this point was I had this adorable patient. She was about 4'11" and about as white as she is tall, cutest thing, but her blood pressure was through the roof, like just crazy. I had her on 7 medicines at one time, and her blood pressure, she's still calling me 2 or 3 times a week and saying, my blood pressure is 180 over 110. And I'm like, I don't know what else to do in this. And so, and she kept telling me, it's my problems, my nutrition and my physical activity. Like, I know I need to do these things and I just can't do it. And I'm thinking, yep, you're right. That's the issue. But here's where things completely changed for me. One of my visits, I'm walking down the hall at Mayo Clinic, and we had couches in the exam rooms, and I hear this horrific snoring, like, rattling the walls. You can hear it all the way down the halls. I'm like, oh my gosh, that's terrible. Like, well, I go, who is it? It's my patient. She's passed out on the couch.
With
I'm
severe sleep apnea.
Yeah, maybe being the brilliant clinician I am, this was a little early. Like, sleep apnea wasn't as prominent. Now every patient, I ask them specifically about these things because it's so common and so underdiagnosed, but it was sleep apnea. I sent her, she would, yes, that's what it was. She got treated. I quit hearing from her. I was a little worried. I'm like, okay, is everything okay? I had my secretary call her. She's like, yeah, I'm fine. I saw her 6 months later. She'd lost 40 pounds. She's on 1 blood pressure medication and is well controlled. And I'm like, what happened? And she told me, I didn't realize what my sleep was doing to me. Once I got my sleep, I had energy. So I started being more active, which made me want to eat better, which just kept building on itself. And so the whole time, her and I are saying, your problem is your nutrition and physical activity, and her problem was her sleep.
Yes.
And that's just a patient story that I think about all the time, is that and I tell patients this, I don't know what your path will be. I don't know what medicines you'll need. I don't know what is going to work for you, but I know how to figure that out. That's what we do when we work together.
And it sounds like it was a process. It wasn't like they come in one day, you talk about 5 things and say good luck, because the real history, the real patient and clinical history comes out with time as you get to know them better as well.
Yep. And that's another example of what Dr. Enright was bringing up, is this, the insurance, if we stay with just an insurance model. And I don't want to disparage that, because I think it's important. I now that I own a business, I pay for the health insurance of my employees. I pay a lot of money for their health insurance, a shocking amount. And I understand people are like, I'm paying $1,500, $3,000 a month for my health insurance. I want it to cover my health. And you're right, it should. But if you just rely on what the insurance is going to cover, you're going to leave a lot of opportunities on the table potentially.
Absolutely. That actually brings me to another question. You describe HealthspanMD as a longevity practice that does cardiology and primary care. How do you define longevity?
Yeah, so longevity is something that I really basically shunned for a long time, because I didn't understand how to define it. There's so many different ways to talk about longevity. It could be the supplement industry, the med spa industry, that now stem cells and, all the other opportunities in this in longevity. And I didn't see that this was something, even though I've always felt I was a great longevity practice, I didn't want that to be our focus. But what I've learned over time is that longevity, one, is what I do. Those are the people, I say with the people that say, I cannot afford to leave healthy years on the table. That's my patient. Like, those are the people, because they're engaged, they have a why, Then they're ready to do what it takes to get that health outcome, that longevity that they're looking for. But longevity is not just how long you live, and so I define the objectives of longevity as strong body, healthy brain, and avoiding the preventable causes of death and disease. Because you really need all three of those. You could have the strongest body and a healthy brain, but if you're not paying attention to your cholesterol, your blood pressure, or your family history of heart disease, you are still vulnerable. So paying attention to all three of those, that's longevity to me.
So that's so interesting because I referred my husband to see you because he has a family history of early cardiac disease, a family member that died of a heart attack at age 45. And he has hereditarily really high cholesterol, like his LDL is like, 190 or 200. And when you saw him, you recommended that we check ultrasound of not only the heart, but also the neck vessels. How is that preventative, and how does that help reduce his risk of chronic disease in the future?
Yeah, so this is a great question. So, assessing risk for heart disease is both complex and also really important. So, the traditional way medicine has assessed risk is an algorithm. We add up all the risk factors and then we say, oh, your 10-year risk of having a heart attack or stroke is X percent. Here's the challenge with that. One, it's good in populations, but it's not good in the individual. And the other part of this is that age is so heavily weighted in that anybody young is low risk and everybody older, over 65, is high risk. And so there's not a lot of nuance to that. But here's the aspect of it that is really important. Screening for heart disease it makes a lot of sense. If we want to know what your risk for heart disease or artery disease is, we should look and see if you have artery disease. I mean, we do that for breast cancer. We do that for colon cancer. We don't do that traditionally for heart disease.
Yeah, I've never heard of that being done before.
Yeah. But by knowing that, the valuable information that that gives us is that it really does come down to cholesterol, not because cholesterol is the be-all, end-all in heart disease. It's because the things that prevent heart disease, I want my patients to do regardless. Eat healthy, not smoke, be physically active, have good blood pressure, not have diabetes, get good blood sugar, insulin numbers, right? But the cholesterol, what is the optimal cholesterol? It depends on the risk of the individual. So somebody that has a cholesterol that is certainly really high, then that's probably somebody that needs treatment. Not always, but probably. If they have a really low cholesterol, then maybe they don't need treatment. But most of us are in that middle. But what's optimal depends on the risk. And so let's take an average LDL. An average LDL in America is 130. So if I see a patient with an LDL of 130 and they're 20 years old and no risk factors, I say, oh, cholesterol's fine. I'm not worried about this. I'm not looking at this. Same exact number in somebody who's had a heart attack last month. That's 2.5 times higher than where I want it to be, because I know if we optimize that cholesterol, they're at the lowest risk of having a recurrent heart attack. And so imaging of artery disease is best for when you don't know what the risk is. Either the patient or the doctor doesn't know what the risk is. Imaging can help you understand that. And it's a really valuable tool because once we know the risk, we're really good at preventing future heart disease. The two tests that are done, mostly it's CT calcium scores. That's the test that's done for imaging for cardiovascular risk. In my practice, we use carotid ultrasound. There's some advantages. It's better in younger people. There's no radiation, but both of those tests, interestingly, are not covered by insurance.
Right. And if you find on the carotid ultrasound that they're making plaque, like in other words, their ultrasound shows that there's plaque buildup, does that trigger you to treat their cholesterol more aggressively?
Well, it certainly opens that up as a possibility. So, I think, it depends on the individual. It depends on what their risk factors are as well. But if the question is, if you are an artery disease maker, is that going to lead us to be more aggressive about managing your prevention regimen? Then the answer is yes. Then I'm going to look at every opportunity. And it's not just cholesterol. Cholesterol is one of our easier options, but I also want to see their blood sugar insulin levels great. I want to see their habits aligned with their health goals. I don't want them to smoke. I want them to eat in a way that's aligned with their health goals as well. But one of those tools that we know is effective in stopping artery disease, even regressing artery disease, is getting the cholesterol great.
That's great information. So when I was reading your WebMD blogs, one thing that I found interesting is that you were often referred to the patients that couldn't tolerate a statin. So if you have high cholesterol and you don't tolerate a statin, what effective options are there available to someone?
Yeah, so cholesterol is a complex topic, and there's a lot of reasons why it's complex. One is, what do you mean by cholesterol? There's lots of different measures. Is it the HDL? Is it the LDL? Is it the particle number? Is it the ApoB? That adds complexity to this. But also in cholesterol, as we talked about, the goal cholesterol, the optimal cholesterol, depends on the risk. So we really have to take into account all of those things. But let's say that we have a patient who has a cholesterol that's higher, LDL cholesterol that's higher than where we'd want, or higher than what their goals are for their health. Then what are our options to lower that? I always love starting with lifestyle change, but the reality is that for most of us, LDL cholesterol is not very changeable with lifestyle change. That's not universally true, but it's only about 10% of people can really move their LDL with lifestyle. Generally, it's with more extreme diets. Sometimes they can lower it with a no oil, like a whole food plant-based diet. Not always. Sometimes I see this not infrequently now that low carb is a lot more popular. A carnivore, a very low carb diet, I've seen people's LDL triple. But for most of us, low carb, high carb, all those things, our LDL is genetically determined. That's just the way that God made us.
That is more just great information. I knew there was some genetics in cholesterol, but I didn't know it was so heavily genetic.
It's the majority driver of this. So, if your goals are to lose weight, to improve your insulin resistance, to lower your blood pressure, those are really amenable to lifestyle change. But LDL cholesterol tends to not be. Now, I always like when people have that, especially if it's not a high risk situation, meaning somebody's had a recent heart attack or stent or those kind of things. And they say, look, I want to try it with lifestyle. And I say, yes, I love that. Let's do that. Just don't be discouraged if in 3 months your LDL didn't change, because you got other benefits. It just didn't show up in your cholesterol. So what do we do in that situation? We've tried lifestyle that didn't work. Fortunately, we have medications that have been around for 40 years that we know more about than just about any other medicines in the history of medicine, and that's statins. Now, I know statins is a complex topic, and there's a lot of contrarianism about that. I will tell you from a cardiology standpoint, and I tell my patients this all the time. Number one, there's a lot of things we do in cardiology that the risk benefit is pretty sketchy. Like, you'd have to really think about, okay, are we really doing good things here or are we not? Statins, cardiologists would say, of the things that I have available to me, tools that have the most benefit for the least risk, most cardiologists are going to put that at the top of their list. I asked one of the fellows to do this research study, and he's looking into it. I'd like to see a survey of cardiologists who are over 50 years of age and how many of them are taking a statin. I take one. My guess is that it's going to be 70, 80, 90% of them take statins. And who has the most experience with statins? Cardiologists. There's the one that they're prescribing it. Do you really think they would be taking it if it's poison and it's killing livers and all those things? So that being said, 90% of people take a statin with no difficulty at all. Why do they take it? Because it lowers the risk of heart attacks, strokes, and death in high-risk people. That's really not controversial. What's controversial is, how do we define high risk? And so Once somebody's had heart disease, everybody's in agreement. That's high risk. Before they have heart disease, when do you get more aggressive with the prevention regimen? That's more dependent on the goals of the patient than it is necessarily on the science of this. So, if statin, now back to your question, let's say that we've tried statins and it didn't work. First, have you tried another statin? Because just because you failed one does not mean you will fail all of them.
So it's not necessarily a class effect.
It is not. Number two, sometimes it's a dose thing. So I've had success in people who have failed statins in the past. And when I say failed statins, almost always that means muscle aches. Like it's not common to have other side effects of statins. Muscle aches far and away the most common one. But it may be a dose thing. And I've had patients where I start them slow and then I'm able to get them on by slowly increasing that. That's not science. That's just a, anecdotal experience.
The art of medicine.
The art of medicine. There you go. The other thing that I'll emphasize about statins, I think this is incredibly clever because, I know I have muscle aches, right? And whether it's a statin or not, like that gets complex. I don't really know. We've always debated that in medicine, like what's real, what's not. A group in England did a really clever study design. They called it the N of 1 study. And basically what they did is for a year, they gave the people, the subjects in the study, a bottle of pills. Some months it was a bottle of statins. Some months it was a bottle of placebos, but they had them track their symptoms on a smartphone. And what happened? 90% of the muscle aches that occurred on the statin occurred on the placebo as well.
Is that the nocebo effect?
That's the nocebo effect. Exactly.
That's
so
fascinating.
Our minds are powerful. Like it is fascinating. Like, even it's so powerful that you can, there's studies that show this. That you can tell people this is a placebo and they'll still get benefit from it. I don't say that to make fun of people. I say that that's a powerful tool. That's something that we have to acknowledge.
So who is your ideal patient? Who do you feel like you can help the most?
Yeah, so my ideal patient is somebody who says, I can't afford to leave healthy years on the table. Like that's the person that they're looking for that, comprehensive approach. They're not just looking for a prescription. They want a structured plan with an expert team to help them achieve their goals. Those are the people that I love to see. I also love to see people that have had a health scare, and they oftentimes when I see them and I tell them 90% of heart disease is preventable, 50% of cancer, strokes, dementia, that gives them hope. Then they say, oh, now I have control. Now I'm not just here having to accept what life offers, to me. I have some control over this. That's a very gratifying thing to me. So those are the people that I really love to see.
Is it fair to say you are a true preventative cardiologist?
Yeah, I love the phrase. I will say prevention is a bit of a challenging thing because prevention, one, insurance companies don't like to pay for prevention.
Right.
Number two, prevention isn't an active problem. And so it sounds good. Everybody says, oh yeah, we should talk about prevention. But the reality is we all have busy lives, right? We have to pay our mortgage. We have to get the kids. We have to do our things. And so those prevention things get pushed off on the, side. So I love the idea of prevention, but where I see people and when I really can help them is often when they've had a health scare that has driven them to that. Then that's when the prevention comes in.
That makes sense because I know my spouse, when his LDL number came back high, he looked at me and he's like, we need to get on this.
Yeah.
Well, I have learned so much today. You are just a wealth of knowledge, and this was so helpful. How do people get in contact with you to schedule a visit with HealthspanMD?
Well, thank you. It's been a real honor to be here. What a great community of people that I believe, are going to change healthcare. Healthcare professionals who have a passion for great care. That's the people that are going to really change things. And I'm just honored to be a part of this. Patients can find me, HealthspanMD.com is my website. We also have a podcast, HealthSpan Podcast. I'd love to hear from people and would love to see people and see if I can help them achieve their longevity goals.
Well, thank you, Dr. Robert Todd Hurst, for coming on Scottsdale Top Docs podcast. We'll see you next time.
Thank you.
It starts with tremendous confidence. And I mean somebody who comes to this thing not as a person who's taken a class or two, but somebody who's literally got their PhD. But that alone is not enough. I would say the second ingredient that Dr. Amber brings to the party is some empathy, but also the ability to nudge people and to get them going. And then the third piece that she brings, which is equally as important, is such a friendly demeanor and a smile. And she lights up our life every time she comes.